Okay, today we are going to talk about constrictive pericarditis, chronic constrictive pericarditis, and especially we would love to differentiate it with restrictive cardiomyopathy, with restrictive cardiomyopathy. Why? Because the patient who come with the constrictive pericarditis, their clinical features and clinical presentations are very similar with the restrictive cardiomyopathy, right? So it becomes very important that we should be able to not only understand constrictive pericarditis after the lecture very clearly, but we should be able to differentiate after the lecture. You must be able to differentiate the cases of chronic constrictive pericarditis from the cases of restrictive cardiomyopathy. Why? One reason that they are confusing. Why they are confusing? Because clinical presentation is same. In both cases there is biventricular diastolic impairment, filling impairment. Secondly, this is treatable. If you do pericardiectomy, you remove the pericardium, in most of the cases there is significant improvement. But in restrictive cardiomyopathy, clinical course is really very sad, right? And you cannot really treat it or cure it, or you cannot have a very good prognosis. Either you know the diagnosis or you don't know. But in case of chronic constrictive pericarditis, in most of the cases, with proper treatment, patient can get a lot of symptomatic relief and hemodynamic relief, right? So due to this reason, it's very important that not only you understand what's wrong in the patient when patient is suffering with chronic constrictive pericarditis, and you should be able to differentiate such cases from restrictive cardiomyopathy. Now let's start with the constrictive pericarditis first of all, right? In constrictive pericarditis, what really happens? In a classical case of constrictive pericarditis, around the heart, pericardium becomes thickened, sometimes not always, sometimes even calcified, and it becomes scarred and shrunken, right? Due to that reason, it does not allow the ventricles to fill properly. Let me make a diagram here that normally what we see, that let's suppose here is the heart, right? So very simple diagram, and here is your pericardium, right? Now, normally what happens that this layer of the pericardium, which is your, which layer? Yes, visceral layer, and other is parietal layer. Visceral layer is adherent with the myocardium, and there's a little bit fluid in between them, that is about 15 to 50 ml fluid, and both layers can glide against each other normally freely, right? And ventricle can go into systole, and then its ventricle will relax, and when ventricle is relaxing, undergoing diastole normally, right, this pericardium, healthy pericardium, has a little elasticity, little stretchability, little compliance. Due to that reason, within physiological limits, when ventricles are being filled during diastole, when ventricles are being filled, this pericardium stretches out, right, and does not hinder the ventricular filling in physiological circumstances, right? What I'm saying, that normal healthy pericardium does not hinder the ventricular filling, right? Both ventricular fillings, of course, during diastole, as it has some elasticity, or we can say stretchability, or we say it is significantly compliant. Now, what really happens in chronic constrictive pericarditis? Actually, pericardium become thickened, fibrotic, right? This is your pericardium, and number one, it can be thickened. Now, in some cases, it may be thickened only on visceral side. In other cases, this may be thickened only on parietal side. But in most of the cases, it is thickened on both sides, and even sometimes adhesions develop between the two layers, so cavity is obliterated. What happened? The cavity is obliterated, right? And so we can say this type of situation occur when there is either chronic injury to the pericardium, that is of course chronic inflammation, or acute inflammation which is relapsing and remitting. Repeatedly acute inflammation is recurrent, right? Acute pericarditis, acute viral pericarditis, if it is recurrent again and again, or this chronic pericarditis, say it is due to tuberculosis, or it is due to uremia, or it is due to some malignant situation, or it is due to irradiation, whatever. So what really happens that when there is either remitting, relapsing acute situation, or there is chronic irritation or chronic inflammation of pericardium, eventually there is fibrotic reaction in pericardium. And pericardium become fibrotic, thick, adherent, scarred, and eventually shrunken. And it may become, in very advanced cases, it may become fibrocalcific scar, right? Fibrocalcific scar is especially present in tuberculous cases, right? And this fibrocalcific scar, when it shrink, now heart is encased, heart is imprisoned, heart is encased in a non-expansile cover, or non-compliant, non-stretchable, non-elastic, you can say, pericardial scar. And this differentiates normal with chronic constrictive pericarditis. What is wrong with the chronic constrictive pericarditis? In most of the cases, not all, I will tell you why not all. In most of the cases of chronic constrictive pericarditis, or a typical case of chronic constrictive pericarditis, due to chronic inflammation or acute recurrent cases, eventually pericardium become what? Fibrotic. But we have to remember one thing, and this fibrotic will actually, what will happen? Encase the heart. And when this shrink, of course during systole, heart contract and become smaller, there is not a big issue. But real problem comes when during diastole, ventricles are relaxing, heart is relaxing, so that it can accommodate the venous return. But when there is such rigid covering, during diastole ventricle cannot relax enough, and if they cannot relax enough, then ventricle cannot fill well, and the function of the diastole is ventricular filling. And if ventricle cannot fill well, we say diastole is not working well. So we say there is diastolic dysfunction, or diastolic ventricular filling is impaired, right? So real problem under this type of constrictive pericarditis is that biventricular filling pressures, right, even if they are more than normal, they fail to fill the ventricles, right? So we can say that this type of situation which I am displaying here, this chronic constrictive pericarditis, the real problem, real hemodynamic problem here is biventricular diastolic filling impairment. Am I clear? Now, another situation can be restrictive cardiomyopathy. In restrictive cardiomyopathy, what really happens, the pericardium is normal. Pericardium is normal. Actually, restrictive cardiomyopathy is primarily a problem or disease of the myocardium. What really happens, that myocardium become abnormal, right? Either it is fibroelastosis occur in the myocardium, or it has abnormal infiltrations or accumulations, like myocardium may be filled with amyloid proteins, or it is filled with hemochromatosis, iron deposits, or it may be having some immunological process like sarcoidosis, and there are many other examples. So what happened in some diseases, as I told you, in amyloidosis or hemochromatosis or sarcoidosis or fibroelastosis or Gaucher's disease or Fabry's disease, or there are so many conditions, right? When there is abnormal infiltration or accumulations or abnormal reaction in myocardium, what really goes wrong is that in these cases, myocardium, okay, let me make the diagram more clear to you, right? This is, I'm showing myocardium. This is of course normal, left is thicker and right is thinner. Now what really happens here, that in this myocardium, right, let's suppose this is infiltration by amyloidosis. Amyloid proteins are deposited here, or hemochromatosis, right? Or there hemochromatosis, there is pathological accumulation of hemosiderin, or there is sarcoidosis and granulomas formed here, right? Now, this kind of situation, what goes wrong with the myocardium? Problem with the myocardium is, as I told you, that normally during diastole, myocardium should relax. right? It should gradually balloon out within physiological limit so that the venous return should be filled in, right? Even though in this case pericardium is normal, but due to abnormal infiltrations and abnormal reactions in myocardium, myocardium failed to relax appropriately. It contracts well, but it failed to relax. What is the problem? Failure to relax appropriately. We can say there is again diastolic failure. Again there is diastolic failure. And again, now do you think venous blood can accumulate properly? No. So the problem here, of course this is systemic cable blood. What is this blood coming? Pulmonary beds. It is coming from the pulmonary beds. It is coming from superior and inferior vena cava, right? Systemic bed. Here also there is resistance. There is resistance to the entry. Is that right? Here also there is resistance to the entry of the blood filling. The difference is here the resistance is biventricular diastolic filling is impaired due to external compression on myocardium by the thick fibrotic pericardium. Here again diastolic failure, but it is not due to pericardial pathology. It is pathology within the myocardium itself, that this is a stiffened myocardium. This is a stiffened. It has become stiff, and you know stiff things don't relax well, right? So this is stiffened myocardium. This is stiffened rigid pericardium. But both of them end up into somewhat similar situation. What is the commonality here? What is the thing common in these two conditions? That both of them heart cannot fill well. So diastolic failure produces the clinical features and hemodynamic. Okay, again I will mention biventricular diastolic filling impairment producing in both cases clinical features and many of the hemodynamic features. Now art of a doctor is that even though basic problem, hemodynamic basic initial problem broadly speaking is similar, we should be able to differentiate these two cases. Is that right? Am I clear? Another thing which I want to tell you, okay, that I will discuss later. Now let's start with this case first, and then we will keep on differentiating with the restrictive cardiomyopathy. As a hallmark, I will just call it constriction. This is constrictive pericarditis. I will just repeatedly in my lecture, I will use the word constriction. And about restrictive cardiomyopathy, I will use the word restrictive. Is that right? So when I say we are talking about this clinical feature is present in constriction and not in restriction, I'm talking about constrictive pericarditis and restrictive cardiomyopathy. So constriction versus restriction. Now let's start first of all pathophysiology of this case.